Okay, good evening, everyone, and thank you very much. So I'll present two short cases just to show how morphology can be similar, but there is a role of molecular pathology in managing these patients. So this is a case one, which is a 57-year-old male, presented with pain abdomen, vomiting, and abdominal mass. On CT scan, he had a heterogeneously enhancing mass at the duodenojejunal junction. And this is the gross specimen where we can see this mass. This is the part of the intestine here. So now histopathology, this was a spindle cell tumor, which was present in fascicles. The mitotic count was 4/50 Hyper field. Tumor size was high, 16 centimeters. So with the spindle cell tumor, we always have differentials like gastrointestinal stromal tumor, leiomyoma, nerve sheath tumor in the GI. So these are the few common differential diagnoses, and we use a battery of immunostains to exclude some and to confirm some. So the immunohistochemical stain that was used was c-KIT, DOG1, CD34, Desmin, SMA, S100, etc., where c-KIT and DOG1 was positive. CD34 and Desmin were weakly positive. So based on this immunohistochemical finding, this case was diagnosed as gastrointestinal stromal tumor. Now, once we have a gastrointestinal stromal tumor, we need to tell about the risk of this tumor. So this is the AFIP risk stratification criteria, which is based on mitotic count, the tumor size, and also to some extent the tumor site. So the duodenal and the intestine, the jejunum and the rectal tumors, they behave largely similar, whereas the gastric ones are a little different. So in the mitotic count, this case has a less than 5 per 50 Hyper field, but it was size more than 10 centimeters, that was, it was 16 centimeters. Location was duodenojejunal junction. So this was a gist of high malignant potential. Now this case received a tyrosine kinase inhibitor in the form of imatinib. He received the treatment for 3 years, and the patient was asymptomatic for next 9 years. Now I have to admit here that the molecular profile testing was not done. It was part of the study which was done in a retrospective manner. So when we did a sequencing for KIT exon 11, 9, 17, and 13, and also for PDGFR exons 12, 18, and 14, this case showed a mutation with G to A transition at 590 codon, and this was a KIT level mutant gist, which shows that this KIT mutant tumors are very much responsive to tyrosine kinase inhibitors. So now I have a second case, which is a 48-year-old male. Again, he presented with the pain abdomen, abdominal mass was there. The patient had anemia. On CT scan, again, there is a heterogeneously enhancing mass, which was arising from the small bowel. This is the gross specimen of that, and you can see the small intestine here, and this is the mass which is mostly exophytic. Morphologically, again, this tumor had similar spindle cell kind of cells present in fascicles, and it was the mitotic count was more, slightly more, 7.50 Hyper field. Immunohistochemically, again, because it is spindle cell tumor, so again, the battery of immunostains were put, and this case again came out to be a gist, which was c-KIT and DOG1 positive. So again, by the risk stratification criteria, this tumor is also a gist of high malignant potential. So this case was given tyrosine kinase inhibitor, but the patient relapsed after 4 months of therapy. It was again operated for the second time, and then there were 2 more occurrences which occurred in the next 2 years, despite the patient receiving tyrosine kinase inhibitor, and then the patient was lost to follow-up. So what is the difference here? On molecular testing, this case did not show any mutation in any of the KIT exons in PDGFRA. So this was a wild type KIT PDGFR wild type gist, which was not responding to the tyrosine kinase inhibitors. So both cases were morphologically similar, but one case was mutant, KIT mutant, whereas the other was wild type. And we know that the wild type gists are very much resistant, primarily resistant to these tyrosine kinase inhibitors. So morphologically and immunohistochemically, these gastrointestinal stromal tumors may be very similar. They immunohistochemically also they can be expressed by these markers, c-KIT and DOG1, apart from the patchy positivity of Desmin and CD34 sometimes. But expression of c-KIT or CD117 on INC does not tell you about the response of the case. It doesn't tell you that the patient will respond to the tyrosine kinase inhibitor. So therefore, to manage or to decide about the tyrosine kinase inhibitor and which patients are good responders, which are poor responders, for that we need molecular testing. Thank you very much.